Hello BMSA, my name is Danny Grave. I am BMSA's Media Chair and tonight's host for Biweekly Rounds. I hope your semester is off to a great start. Tonight we'll be having guest speaker Ethan Geiger PAC give us some advice and answer some questions asked by you guys. Just for a little bit more well-rounded approach on his way into the medical field. But first, we're going to have a quick word from our officers about all the great events going on in the next 2 weeks.
Hi BMSA, welcome back to another general meeting. My name is Delaney Shu and I'm your president for this school year. Just a friendly reminder to pay close attention during the meeting. The speaker and the media committee took a long time to put this together for you guys, so just be respectful. Make sure to fill out the Google form in the description box for your 5 general points, and reminder that you have to get 50 points this semester, 10 academic workshop, and 10 service. Thank you guys and enjoy the meeting.
Hi everybody, I'm Sarah and I'm your service chair this year. I want to thank all of you guys for participating in our Free Rice Week of Service. Online service is still continuing, and I suggest you guys look into both our letter writing campaigns with the Boys and Girls Club as well as Bluebonnet Hospice, and keep signing up for Beacon. It's a great way to get your points online. Thank you.
Hi everyone, my name is Jessica and I'm one of your Global Health Co-Chairs. I just wanted to highlight some of the amazing events we have coming up in the next couple of weeks. First, we have on Wednesday, October 4th, Medical Spanish at 5:30. And we also have on Tuesday, October 20th, Global Health Outreach at 5. Make sure to join us for both of these Zoom virtual events, and we hope to see you there.
I can't wait for you to come my way. I've been far away, but I'll keep running.
Hi everyone, my name is Kristen Salinas and I'm the outreach specialist for the Princeton Reviews, Texas, and El Paso region. So today I'm going to talk to you about our MCAT. So I'm going to give you some basic information about how the Princeton Review can support you in reaching your individual goals. Also, please make sure that you scan the QR code and enroll to be entered into a contest for a free test prep scholarship. I'll go ahead and leave the code up for just a sec. All right, so the MCAT is a computer-based test that tests your physical and biological sciences, verbal reasoning, and writing skills. In 2015, the AAMC added a new section called Psychological, Social, and Biological Foundations of Behavior. This section tests your ability to understand sociocultural, biological, and psychological influences on behavior and social interactions, as well as how people process emotion and stress. If you're planning to take the MCAT within the next year, please make sure to check out the AAMC's websites for the most up-to-date information about the testing administration's COVID plans. So what is the MCAT? So admissions officers use the MCAT as a predictor of what your success in medical school will be. So the exam is designed to test the skills that you'll use when you get there, including basic sciences, verbal reasoning, and writing ability. The MCAT is 7.5 hours, and it's a computer-based test that has the reputation for being one of the most challenging standardized tests. So how's your MCAT scored? Each individual section on the exam is scored using a 118 to 132 range, with a median score of 125. You'll receive a score for each section, plus an overall score. Total scores will center around 500 with ranges from 472 to 528. Med school admissions committees typically consider applicants near the center of the range rather than placing the most emphasis on the higher end of the scale. The MCAT is a scaled exam, meaning that your raw score, which is based on the number of questions that you got right, is converted into a scaled score that takes into account the difficulty of the questions. Because different versions of the test have varying levels of difficulty, the scale will be slightly different varying from one MCAT administration to the next. Make sure that you plan appropriately, as a score does take 30 to 35 days to come back, and it is recommended that you take 3 to 6 months to prep for what will probably be the most challenging test of your life. So what's important to med schools? Med schools are looking for the complete package, not just strong scores and a high GPA. It takes a strong combination of all of them, of all of the items listed on your screen to tell the full story and to get you into medical school. GPA and MCAT scores are two of the most important items that schools consider just to get your application considered. Remember that if your GPA is on the low side, you'll need a higher MCAT score to compensate. And if you have a strong GPA, you can get away with a lower MCAT score. Most schools will preliminarily screen your application for your GPA and MCAT scores, meaning that if your grades and your GPA are not above the school's arbitrary threshold, then the rest of your application will not be reviewed and you will likely receive a rejection. If you decide that you need to retake the MCAT, you can take it up to 3 times a year, 4 times in 2 consecutive years, and 7 times in your lifetime. Just keep in mind that all of your scores will be seen by medical schools through admissions committee, though admissions committees will use your MCAT scores in different ways. Depending on the program, schools may consider your highest score, they may take the average of all of your scores, they may give greater weight to your most recent score, or they may only consider the highest section scores from each of your tests. You'll only want to take this 7.5-hour test once, so make sure that you're as prepared as possible for that first time. So med school admissions. Fierce competition is an understatement. Over the past 3 years, the acceptance rate averages only 41.9%. Most pre-med students that actually apply to an average of 15 programs. And the number of applications continues to rise every year. Our med school admissions experts typically advise pre-med students to send 50% of their applications to their target schools and 25% to their reach and safety schools respectively. This means that if you're applying to 15 programs, about 8 of those applications should go to target schools that you have a fair chance of admissions based on your MCAT score and GPA. 3 should go to your reach schools where your scores fall below their GPA and MCAT average. And the remaining 3 should go to your safety schools, which are schools that your GPA and MCAT scores are well above the average range of acceptance. Don't freak out. Use resources to help you compare your grades and scores to the average scores for medical schools on your lists to get a sense of how you do in the application cycle. Make sure that you join extracurriculars and gain relevant experience as early as possible. They look for diversity over quantity, and paid experience is recommended. Make sure you take a free practice test to get a solid baseline of where you currently are so you know how much work you will need to do. Identify your strengths and weaknesses and guide your content review with your free practice test results. Give yourself enough time to study and practice. Consider taking a glide year. So if your GPA is not where you want it to be, take some time to gain that experience and build your prep. You should take your MCAT once you've completed your prereqs. You should start your prep between 3 to 6 months before the actual exam. And most students who do well on their MCAT spend between 200 to 300 hours preparing, so make sure you're giving yourself time. Prep. Make sure that you invest in a prep book to streamline the need to know information in one place. Review with experts if you can, who know the exam inside and out. And if you choose to take a course, make sure that you choose a course that works with your schedules and your specific goal plan. So we've got your back. For more than 35 years, students and their families have trusted the Princeton Review to help them get into their dream schools. Our mission is to provide personalized, innovative, best-in-class private tutoring, test prep, and admissions products and services to help students knock down barriers and achieve their academic goals. We'll provide the support that you need to boost your GPA, prep for your MCAT, and guide you through the admissions process with you in mind the entire way. Need to boost your GPA? Try homework help. From tackling tough homework assignments to studying for a big test or writing an essay, our tutors are available to help 24/7. Connect with an expert tutor on demand in 60 seconds or less and ask any questions in over 80 subjects. 96% of our users improve their GPA with homework help. If you have test anxiety, try test success. Test anxiety is simply nervousness which people may feel before, during, and after engaging in any sort of academic assessment. A small amount of test anxiety can actually serve to motivate us as we work towards doing our best on the test. However, if you are not mindful of test anxiety, it can hinder your performance and actually compromise your success on a test. We will teach you how to turn your knowledge into real results on any exam through our expert coaches, our no stress assessment, and live instruction of practical strategies taught in a supportive group setting. Prep with the best. We know the two main reasons that students struggle: lack of prep time and too much to memorize. This is why we prioritize maximum results in minimum time. We offer a variety of prep options to help our students find the right fit for them. Our courses are taught by the most in-demand instructors and who are subject matter experts, not generalists. Plus, all of our courses guarantee results. MCAT 515 Plus, Score Guaranteed Live Online Immersion, is our most intensive score guarantee course delivered through our proprietary live online classroom. It'll jump your score to the 92nd percentile while making you a competitive applicant. Our 510 Plus Score Guarantee course helps you reach 510 or higher score with 123 hours of classroom instruction designed to quickly eliminate any areas of weakness, guided by your personalized study manager to help you keep you on track to reaching your goals. Our MCAT Ultimate course is a super skilled teaching and a major arsenal freestanding passage-based questions course, empowers you every step of the way. 123 hours in the classroom with a team of 4 to 6 subject matter experts will get you the score that you're looking for. Winter Boot Camp. We offer a winter boot camp between December and January, which will allow you to turn your winter break into a 510 plus score. You'll spend 4 to 6 weeks with specialized instruction designed to turn your MCAT score into a smash hit. We also offer self-paced options. Our self-paced options are guided by our individual hands-on tools, all of our online resources, and all of our practice tools. And lastly, we offer private tutoring options. Private tutoring is our most personalized approach. Our expert tutors and dedicated tutoring manager work with you to make a plan, set goals, exceed them with a customized schedule and lesson plan designed to fit your specific needs. Plus, exclusive online instruction tools. Princeton Review students gain immediate access to our exclusive online content that supplements their course. You'll gain access to our MCAT dashboard, which is our industry-leading dashboard, which gives our MCAT students the ability to manage their coursework, track progress, and take their practice tests. Our MCAT topic focus is a live online MCAT office hours. We also offer Medflix, which is 500 plus expertly crafted on-demand videos that target specific content areas that you can focus on reviewing exactly what you need to when you need to. We also offer diagnostic exams from biology to cars. Each separate MCAT subject comes with its own sets of paired diagnostic exams, so you can measure your improvement and know which topics need extra attention. You'll also receive access to practice tests and detailed score reports. Our full-length practice tests give you the true MCAT experience. Interactive score reports provide detailed analysis of what you'll need to focus on to improve. And drills. Freestanding and passage-based questions are all about strategy, and we offer a magnitude of drills accompanied by detailed explanations to help you lock in early learning when it is right for you and learn from your mistakes. If you want to try us out, go ahead and sign up for our MCAT free trial. So if you're serious about your MCAT prep, then we've created an opportunity to celebrate MCAT registration. For the first time ever, we've made our entire biology course free. Every single lesson, every single homework assignment, and every single tip and strategy that we have on MCAT biology. During this 14-day course, you'll get all of our biology diagnostic exams, all of our biology on-demand course videos, 3 online passage-based drills using the same interface as the real test, a full-length practice exam, so you'll get a taste of what test day might be like, and a detailed interactive score report with in-depth explanations for every item on the practice exam, so you'll understand where you need to improve. And we also offer med school admissions counseling. Med school admissions is fierce, so it's our job to help get you noticed. To do that, we offer a variety of valuable med school admissions counseling options to best support our students' needs. If you're currently a pre-med student, I definitely recommend you start now with our pre-med early counseling program. Shape your pre-med experiences into ones that will catch the attention of any medical school. With our pre-med early counseling program, our admissions experts can help guide you to make the right decisions every point of your pre-med career starting now. We also offer premier admissions counseling, which is an all-inclusive personalized plan that'll help you gain a competitive edge in the medical school admissions process, and it features exclusive support from our premier counselor. We also offer a comprehensive admissions counseling package. Tackle your primary and secondary applications with an experienced healthcare admissions counselor and admissions support coach. You can also do self-paced medical admissions counseling to tackle the admissions process at your own pace with the best advice from our expert coaches and counselors. And lastly, we offer a la carte services, which include personal statement review, interview prep, and rejection review. Now there's an app for that. So download our free Connects Q&A app for a tutor in your hands. Instantly get solutions to your math and science problems by our AI search engine. If our instant answers aren't enough to assist you, you can connect with a live tutor. Stuck on homework? Connects has 24/7 live tutors. Tired of typing in questions? With Connects, just take a photo and get an instant solution. Tired of partial solutions? Connects always provides step-by-step solutions. Get help today. Now, as a partner with the Princeton Review, you do have partnership benefits. As an appreciated partner with the Princeton Review, you qualify for exclusive discounts. All members receive 15% off prep courses and 10% off private tutoring and med school admissions counseling. Reach out to your officer board for more details. If you already haven't done so, please make sure that you enroll to get entered into this contest by scanning the QR code on your screen. This brings me to the end of my presentation with you today. On the screen, you'll see the contact information to your local grad expert, which is me. I'd be more than happy to answer any questions that you might have, but if you're looking for help on researching programs, analyzing your scores, or creating a goal plan, please scan the QR code on your screen to schedule a consultation with myself. We'd also greatly appreciate it if you followed our local Facebook and Instagram pages for local updates, exclusive discounts, and contest opportunities. I appreciate you taking the time to listen to me today, and good luck with all of your future endeavors. Thank you. Have a great day.
Hi everyone, I'm Daniel, one of your Global Health Co-Chairs, and I just wanted to tell you all that unfortunately our domestic trip to the Rio Grande Valley has been canceled because of spring break scheduling. However, our international trip to Peru in May is still on, and you can find information about it in the weekly emails that we're going to send out this week and the coming weeks. Thank you.
Hey guys, it's Jasmine with Coys here, and we are excited to announce that we're going to be hosting our first workshop of the semester. It's going to be about how mental health correlates to having a healthy lifestyle. So it's going to be on Monday, October 12th from 6 to 7 p.m. via Zoom. So check it out on the event sign up, and we hope to see you there. Thanks.
All right, now that we know what's going on in these next 2 weeks, we're going to pass it on over to our Vice President, Cameron.
Hello and welcome. Thank you for tuning in. My name is Cameron Campbell, the BMSA Vice President. Hope you all are staying safe and healthy, and you enjoyed our last recording, which was our very first general meeting. Like I said before, we didn't want to completely eliminate general meetings entirely due to COVID, and so our executive board has been working very hard to still get you all the same guest medical speakers and allow you to ask your very important questions. And so this week we have a very special guest who our very own President Delaney Hsu works very closely with, Ethan Geiger, who is a native Wacoan who grew up in China Spring, is a physician assistant, and he loved Waco so much he came back to practice at Waco Heart and Vascular, which specializes in cardiology. And so without further ado, Ethan Geiger, thank you so much for being here.
Hi, I'm Ethan Geiger. I'm a PA. I've been practicing for almost 3 years, solely in cardiology. Practicing here in Waco. Currently I'm with Waco Heart and Vascular Cardiac Clinic in town. Yeah, so I was raised here in Waco, China Spring actually, and spent my undergrad at Texas A&M, which is a good school and not culty, and I do say howdy sometimes, and I walked on the grass. I did. Okay, so giggle. Also, y'all might get an interview there, so don't crap on them just yet. Okay, I was a biology major there, and in a last-ditch effort to make myself look more attractive to different schools, I got a business minor, which basically taught me that I didn't know anything about business, and that I was very bad at working with computers. So that was cool. What made you interested in the medical field? I've been surrounded by medicine for my entire life. My father was a practicing OB here in Waco with the Family Health Center. My mother is currently an OT, occupational therapist, and I've always been interested in science and interested in the human body and how it works. And obviously you have to say that you got into medicine to help people, or else you just look like a bad guy. I went to school at UTMB, PA school, from 2015 to 2017, did my rotations in Galveston and in Houston, and majority actually in Waco with Baylor Scott and White and the Family Health Center. Yeah. So, the application process, if anyone started it knows it's a load of crap, and it's uncomfortable, and it's time consuming, and it's not fun, and it is very unrewarding until the very end. It's a lot of busy work. Letters of recommendation are a pain because majority of the people don't respond to your emails requesting the letters of recommendation, and then you have to track them down, and then you have to ask them again, and then they still don't respond, and that's always fun. Healthcare experience and patient contact documentation. It's very hard to get that if you're not a skilled employee or a skilled professional. So I remember documenting taking temperatures and picking earwax out of a patient. And, you know, I counted the earwax one for about half an hour of patient contact. You got to stretch it out as much as you can. Shadowing hours, pretending to care about what the doctors or the mid-levels have to say while you're in the room, and standing on your feet for 8 hours a day, pretending to be interested. Personal statements. That comes back to the whole helping people thing. If you don't put that in, you're not going to get in, okay? That's just a word of wisdom. So in interviews, to be honest, I had 2 interviews. One interview was the year that I applied first and I didn't get in, which was very intimidating and taught me that you don't talk about politics in a professional school interview, especially one in the height of the Affordable Care Act and polarizing issues such as that. The second one I did get into, which was UTMB. I had the interview, and halfway through they said, well, we want you here. Tell us why, or what we can do to get you to come. So that was pretty rewarding and encouraging. Okay, so, you know, 2 ends of the spectrum. Majority of people, majority of y'all will have more than 2 interviews, so y'all might have a little different story. Professional school as it was a lot of fun. It's not like going to undergrad where you're spending countless hours studying about the Slovakian migration. Okay, this is something that you're actually studying what you're going to be doing for the rest of your life, and that is encouraging and that is motivating. It's not like undergraduate where you have dedicated and dictated study plans. This is a lot of independent and self-reliant learning. So if you're not motivated to do it, you're not going to do it. So that was something that I learned very quickly. Like I said, it's end goal driven. The product that you're striving for is your career. So once again, it helps you along the way whenever you get discouraged, thinking, well, this is going to be at least over in a couple of years, and I will get to where I'm going. And I formed some of the most consistent and valuable relationships to this day that I still have from PA school. You know, mainly because these individuals are my peers. There's people that share my interest and my passion for helping people. No, I'm just kidding. Actually helping people. So, you know, they're good people and good relationship that you're going to have the rest of your life. So never take that part for granted. So some of the most challenging obstacles. This was a fun one, okay? Because my work environment, as one of y'all's peers can attest to, is a bit challenging at times because of the dynamic I have with my supervisors. And if y'all don't know, PAs have to have supervising physicians sign off on 10% of your charts. Okay, so some roles have a helicopter supervisor who's there every single day, critiquing and monitoring and making sure you're not killing people. And other situations, not so much. So accepting my role and limitations in the healthcare community was one of the biggest challenges, especially in the situation that I'm in currently. PAs have a very strong role in family health, family medicine, and primary care. The more specialized you get, the less that you're able to do. Okay, so as a cardiac PA, my roles can be limited as far as that's concerned. And then advocating. 99% of the old people that come in still think that I'm a medical student or a nurse, which is nothing wrong with nurses. I'm just not one, and haven't been. So that's always fun. Leaving the room and saying, okay, we'll see you in 6 months. And they say, great, when am I going to see the doctor? I said in 6 months. So anyway, educating, that goes along with advocating. I might have just duplicated efforts by putting both of those in there, but I wanted to really get the point across. But yeah, educating. Educating people on what I am, what my profession is, what I do, what I can do, what I can't do, and making sure that these patients are comfortable and confident with the care they're getting from not an MD. So that's always been fun. So the biggest thing is it's physician assistant, not physician's assistant. Yeah, get it right. Okay. They've played around with changing the name. That's never going to happen. And unfortunately, because it does kind of what am I thinking of? It kind of makes this profession seem less than what it is. But educated people understand that, and I appreciate it. Off my soapbox. Some of the more exciting and interesting things you didn't foresee about being a PA. Autonomy of practice. That kind of goes hand in hand with what I said before, that the longer that you're practicing, the more comfortable you are in the setting you're in, the more comfortable your supervising physician is in the setting you're in, the more you are going to have as far as autonomy. Like I said, primary practices are more autonomous. Specialized still has that, well, I can only do so much because the MD and the DO is going to, obviously they're specialized for a reason. So I'm not going to do what they do on as far as that's concerned. But mid-levels are becoming a lot more autonomous, running their own clinics, and that's exciting. Broadening scope of practice kind of goes along that line. Potential procedural capabilities. There's mid-levels doing heart caths, not interventional heart caths, obviously, but diagnostic heart caths. And I'll get to what a heart cath is in a second, if anyone doesn't know. So that's fun. All right. Actually, we're going to talk about it right now. So, some of the things we do in the clinic are heart cath procedures, left heart catheterization procedures. These are procedures that explore the coronary anatomy, and that's where we can deliver stents, we can do angioplasty, we can do atherectomies to remove burdensome plaques within the coronaries. Heart attacks come from ruptured plaques. So there are emergent heart catheterizations where someone has a heart attack, STEMI, and they need urgent intervention. And then there's elective heart catheterizations where someone comes in with chest pain, shortness of breath, fatigue. They come in with some sort of anginal equivalent. Typically, we'll do a stress test unless otherwise indicated. If stress test is positive, and a stress test is either a treadmill where we're measuring ischemic changes with an EKG versus a nuclear stress test where we're actually injecting a radioactive tracer that is picked up, and pictures will then show if there's any perfusion defects, which would then indicate ischemia. If those are positive, we take them to the cath lab. Either run up through the radial artery or through the femoral artery with a catheter wire that goes to the coronaries via the aorta, and we pump dye through the coronaries and then look at that on an x-ray and identify if there's any kind of plaque burden or blockage present. So I would like to show you some of these things briefly, and cross your fingers. So here's just a general representation of a diagnostic coronary angiogram. You can see up here is this is the heart. Whoa! Shoot. This is the silhouette of the heart. Up here at the top is the catheter, and we're pumping it through. This is the left distribution, and obviously it's a diagnostic heart catheterization. So there's no major blockages present there. All right. Showing once again, the left coronary distribution. And the right. Cool. And now we're going to do an actual angioplasty. Once again, my business minor taught me how to work with computers. So this is the meat and potatoes here. This is actual intervention. This is fixing the blockage. You can see here where this red circle is a stenotic artery. And up here is the guide wire about to poke itself through. And that follows down the arterial path. This is a balloon with a stent around it. So that's snaked in there where that tight little piece is. And then the balloon will expand that stent, crushing the plaque into the wall, opening that artery. And there's the stent. And it worked. Where I'd ask if you had any questions, but talking to a computer. All right, cool. So my practice is mainly focused on, we do atrial fibrillation, which is an arrhythmia that comes from ectopic atrial nodes. Biggest concern with atrial fibrillation is stroke risk. So that's why when you have AFib, or if you have a relative if you have a relative with AFib, they'll be on an anticoagulant like Eliquis or Xarelto or, God forbid, warfarin. Fun fact, they were going to implement warfarin to kill off the wild hogs, the feral hogs in Texas. Obviously, for multiple reasons, that didn't pass, and it was never implemented. So, but warfarin's not good. Chronic conditions such as hypertension, hyperlipidemia, diabetes, not so much, but these are things that are precursors to coronary artery disease, which is what we focus on. So we got to make sure that your blood pressure is controlled, your cholesterol is controlled, your sugars aren't out of whack. And then obviously coronary artery disease. So like I kind of walked through before, someone comes in with risk factors, they come in with chest pain, shortness of breath, fatigue, any anginal equivalent, that's going to activate kind of the, what's going on protocol, coronary artery disease protocol. Labs, risk factor assessment, stress testing, potential PCI, potential stenting, angioplasty as such. Heart failure is a big part of it as well. That's one of the most frustrating conditions that we deal with, I think, because it's such a patient-dependent condition. If you have someone with heart failure, they can be very, very, very well controlled, and then they go out and they have a pork chop and they end up in the hospital. So education and patient compliance is crucial, and unfortunately very difficult to obtain. We also do a lot of pacemakers and ICDs. So pacemakers are internal electrical devices that stimulate the heart. They're very complicated, and I don't know enough about them to talk about them. I know what they do, and I know who gets them. Okay. Also, we do ICD therapy, implantable cardiac defibrillators. That's a subset of patients either with known ventricular tachycardia or life-threatening arrhythmias, or with heart failure patients that are at higher risk for life-threatening arrhythmias. Peripheral artery disease is a large part of our practice, and similar to coronary artery disease, you can develop plaque and cholesterol burden in the arteries of the legs. Actually had a guy not too long ago who didn't follow instructions, and the next time I saw him was in the ER, and subsequently had his leg amputated. So peripheral artery disease is a very widespread condition, and unfortunately oftentimes leads to amputations. So there's a lot of risk factors that go into that. Primarily is diabetes, if not more tobacco or smoking. So don't smoke and don't do diabetes. The more you know. You can take that out. So the case study, this was awesome. This was very interesting because for once I got a win, and I was excited about it. This happened 2 days ago. So this was not an old guy, a 63-year-old male with history of non-Hodgkin's lymphoma, is in remission, has history of atrial fibrillation, status post atrial fibrillation ablation, which is similar to a cardiac catheterization in the grand scheme of things, except that it's not. You're using vein access, and you're using either alcohol ablation or radio frequency ablation to destroy the atrial source of the the source of the atrial fibrillation arrhythmia. And that's typically done by an electrical physiologist specialist. So this guy had an AFib ablation last month. He had frequent PVCs. He's had them for the 6 months that I've known him. Ultimately took him for a heart cath last year, just trying to work him up. Moderate LAD disease, no significant obstruction, nothing needing intervention. This guy is chronically hypotensive despite being on antihypotensive medicines and despite being on steroids. It's just been very, very difficult to keep his blood pressure up, so it's been frustrating for both of us. He has very bad gastroesophageal reflux disease, and last week was diagnosed with pericarditis secondary to a pericardial fusion secondary to the atrial fibrillation ablation. So, and we gave him colchicine, and like I said, he's chronically on steroids. So all that to be said, this history of presenting illness history of present illness is a lot of different conditions that can cause chest pain. So he came back in yesterday with progressive, broad, not one side versus the other, not really any pinpoint pain, but just broad chest discomfort that was worse with breathing, even minimal. So he was very short of breath because he couldn't take deep breaths. It got worse when he laid on his back, and it got better when he arched his shoulders. Not the typical presentation, better with leaning forward. That doesn't do much for him. He had severe fatigue. His reflux was acting up, and he was short of breath, like I said, probably because he could not take deep breaths. It was stabbing, and it was ongoing since yesterday after he mowed the lawn. Like I said, recent ablation. He developed pericardial effusion after that. We treated with colchicine for pericarditis. We repeated the echocardiogram last week, and it showed the effusion was better. His vital signs were 100 heart rate, normal for him. His blood pressure 91/61, like I said, chronically hypotensive, so normal for him. His temperature was 98.2. His O2 was 96, lower than normal, but not alarming. So no red flags here because of the patient that I was dealing with. No non-specific ST changes. It was just sinus tach, and minimally sinus tach. His echo preserved EF, no heart failure, mild diastolic dysfunction, and like I said, improved pericardial effusion. So what's next? Differential diagnosis. Pericarditis, chest pain, worse with deep breathing, better with position changes like leaning forward, worse with lying flat. He had a recent atrial fibrillation ablation, treated last week with colchicine without improvement. So that told me, hey, it's probably more than just that. Gastroesophageal reflux disease, old GERD, associated with nausea, GI upset, acid reflux, better with antacids. He had no relief with antacids. So I said it probably is also that, but we're not going to stop there. Acute coronary syndrome, chest pain, shortness of breath, fatigue, nausea, vomiting, radiates to the left arm and back, can have EKG changes, but not always. So that kind of said, oh, maybe it's that. It happened after you mowed the lawn. Sometimes it can present in weird ways that we just don't know. You know, he had a moderate heart cath last year. That can progress. So I couldn't rule it out, and honestly kind of clung to that as a way of convincing them to take the next step, which was the ER. Aortic dissection, tearing, chest and back pain, medical emergency, not going to come into clinic for it. Pulmonary embolism, short of breath, pleuritic chest pain, which is pain with breathing, typically associated with hypoxia, hypotension, and tachycardia. So remember, he had hypotension, he had tachycardia. His oxygen was not that bad. But, to my defense, he was always hypotensive, always tachycardic. We're going to learn that lesson, though. So that's pericarditis, generalized ST elevations, not in the pattern of an acute STEMI, which is ST elevation myocardial infarction. So this is pericarditis. He did not have this, or at least he didn't have this EKG. Here's a STEMI. You have these tombstoning. This is going to be a left anterior STEMI. God, I hope no cardiologist watches this because I might be completely wrong. So this is a left anterior STEMI. These ST elevations indicate that. And then over here we'd also have some ST changes here and here. Well, this is a rhythm strip. Maybe this is just an anterior. We'll call it anterior, they can criticize me later. So this would indicate a heart attack, an acute heart attack. He did not have this. Pulmonary embolism. You'll never see it, but it's an S1, so an S lead, or an S wave in the lead 1, a Q wave in lead 3, and a T wave in lead 3, which is an inverted T wave in lead 3. He didn't have it. Aortic dissection. This is just an X-ray showing that this is an enlarged silhouette of the aorta. I didn't get a chest X-ray. I almost did, but I sent him to the ER. What do? We send him to the ER for a higher level of care. Pericarditis, unlikely, no response to colchicine, pain out of proportion. He got worse on colchicine, which is an anti-inflammatory medication we use for pericarditis. Echo demonstrated improving pericardial effusion. Acute coronary syndrome, maybe. Occurred after exertion, chest pain, nausea, reflux, radiates to back, and short of breath. History of moderate LAD stenosis, no EKG changes. We need a lab to confirm that. That's what I was hoping it was not, but why I said go to the ER. Reflux, maybe, probably also happening, but it was not the cause of his pain. You can have reflux symptoms with heart attacks. Aortic dissection, unlikely. Emergent condition, probably would have walked into the office. Pulmonary embolism, PE, bingo. I checked on him this morning. His D-dimer was greater than 2,000. It's a very non-specific tester, but if it is positive, then there's something going on. If it's negative, it's not a clot. Positive means it's something. We activated, or the ER activated PE protocol. A CAT scan of a CTA was ordered, and it was positive. He had a handful of left-sided pulmonary embolisms. So we solved the problem, or we diagnosed the problem. And why is this interesting? This guy was on Eliquis, an anticoagulant for AFib, which in theory, in principle, should have prevented any kind of thrombus or embolism. It's interesting because he's always had low blood pressure. He's always had a higher heart rate, but maybe that masked the possible pulmonary embolism effect. O2 wasn't that low. Takeaways. Never ignore vital signs even if appear to be patient's normal. That's my big one, because that is why pulmonary embolism didn't even come into my differential that day. Okay? Always trust your gut, even if your doc's going to yell at you for being an idiot. Sometimes you're right. I might have bloated this morning, okay? And that's okay. You can do that. Know your limitations in clinic. Don't let the patient decide what you are going to do. He didn't want to go to the ER. He didn't want to be admitted. His wife didn't want him to go to the ER. She didn't want him to be admitted. But if they gotta go, they gotta go. And accept and own the consequences of your decisions. So fortunately for me, it was the right call. If it weren't, the guy would have been pissed off and I would have dealt with that. But if it would have gone the other way and I would have sent him home, it could have been much, much worse. So always err on the side of caution as far as that goes. All right, cool. And we can ask questions if we want to about that later. So what advice would you give to our freshman Baylor students about pre-health, whether it be motivational, academic, social, or religious? Study. Make sure your GPA is good. They don't want dummies in medical school. I mean, come on. Get experience early. Don't wait till the last minute, because then you are literally sitting in a clinic for 8 hours standing because there's only 2 chairs in a patient room, one for you and one for the patient and one for the provider. So you're standing a lot. Maintain associations. Have these organizations that y'all are part of. They're invaluable, and I wish that I would have done more of them. Enjoy college always. You only go to college once, hopefully. And it's really fun, and it's not that hard. And when you get out of it, you have a mortgage, and you have now 4 dogs, and one of them is a puppy, and it poops in your bed. Regardless of if you take it out 6 times, you'll take it out, he'll bring it in, he poops in the bed. So enjoy college. Marriage is great, but then she buys a new dog, and it poops in your bed. So, enjoy college. Sorry. Last thing. I know I said I went to Texas A&M, but my best friend went to undergraduate and law school at Baylor, and like I said, I'm from Waco. I'm from China Springs, so I frequented the MRF. Stay away from the MRF. Nothing good happens at the MRF. Thank you.
Alrighty. Well, thank you so much, Ethan Geiger, for such a wonderful presentation for our members. And thank you all for submitting your questions. Now we're going to go on to the Q&A portion of our meeting. And we got a lot of submissions this week. Thank you all so much. If we don't get a chance to answer your questions this week, don't be discouraged. Please ask for next week. We can only ask so many questions in one day. And also, don't feel that your question is too dumb. The only dumb question is the one not asked. Because if you're wondering it, there's 659 other people. At least one of them is probably thinking the same thing. And also, take advantage of being able to submit your questions online. Because I know it's pretty intimidating to ask your questions in a room of 200 people. So now you have the opportunity to do so, if you don't feel comfortable doing that. And so we will begin with our first question. That comes from Genevieve. She is a health science studies pre-PT major from Katy, Texas. And she asks, what advice can you give on picking your post-undergraduate PA, PT, etc. school?
Number one, whoever gives you an interview. But number two, it's a multifaceted question, okay? Because my honest answer would be go to the place that you're going to enjoy the most. Like I went to University of Texas Medical Branch in Galveston, so I was on a beach, be it not a great beach, it's still a beach in a beach community. So that was the best learning environment that I could have, and equally competitive and equally educational. And you're going to, every single school has to meet guidelines and meet criteria before you graduate. So you're not going to not get a job if you go to this school versus this school. So the preference on how do you choose what graduate school to go to or what professional school to go to really has a lot of different factors, but primarily mine was where am I going to want to be for the next 2 to 4 years.
Mm-hmm. Good advice. A lot that I think people overlook thinking about that. And so our next question comes from Shanique Wadar, and she is a biochem major from Shreveport, Louisiana. And she asked, did you ever consider becoming a physician versus becoming a PA? And if so, what influenced your decision to become a PA? We had a lot of people ask this type of question.
Yeah, great question. It's something that I've struggled with for a long time. Because the easy answer and the simple and the honest answer is I didn't want to take the MCAT. And, if I would have, like I said in the presentation, done the things early and involved myself early with organizations that really do help you understand what your what requirements you have to do to go to that next step, I think it would have been a lot less daunting than me trying to figure it out on my own. So, whenever it came to applying potentially and taking the MCAT, I took like a crappy Princeton review and went to a handful of the classes, and then didn't take the MCAT because I was like, well, hell, I don't want to fail it, And then because this was after I graduated, I took my time really making those final steps and final preparations, and then got a little bit overwhelmed at that juncture. So then PA really became much more attractive because, number one, like I said before, no MCAT, which retrospectively is a terrible reason to make this decision. Terrible reason. But PA versus medical school, the time requirement is obviously 3 years versus potentially 12 years depending on residency. But and once again, retrospectively, the application process and interviewing and getting into a PA school program was much more difficult and competitive than I had anticipated. Mm-hmm. So the easy answer is I didn't want to take the MCAT. The long story is I made a kind of a jump decision to change my entire path because I was lazy. But I also don't want to discredit and undermine the difficulty of getting into PA school, the difficulty of completing PA school, the difficulty of being in the reward of all of that. So the reason I didn't go to med school was because I was lazy. But ultimately, it's worked out.
Very interesting. Very cool. And so our next question comes from Rachel Herlin. She's a neuroscience major from Mission Viejo, California. And she asks, what do you wish more people knew about physician assistants? I mean, is there any misconceptions about them? Like you said, it's not physicians, it's physician. Anything
Yeah, that's
like
the big one. That's the big one. Yeah, the name is a terrible name because it does kind of denote some sort of
inferiority.
Inferiority. Yeah. I mean, because the comparison is a nurse practitioner, right? So, which that is a very direct comparison. But somewhere along the lines, we just kind of either the patient or the public doesn't understand what it is, so then we do have some of that inferiority connotation. What was the question again?
What are some things that you wish more people knew?
Yeah, and that PAs are capable providers. We're not nurses. We're not in training. Once again, nurses are great, but we're not that. We're not in training. We're not training to become a doctor. This is not a stepping stone in our career. This is our career. We're capable of treating and diagnosing and caring for patients, and not, I just wish that more of the public was comfortable and was knowledgeable about what this profession is and what we provide to the healthcare community.
No, yeah, I think all that's incredibly true, especially what you're saying about people have this misconception of being inferior to a physician or something like that. My mother had serious spinal surgery, and she thanked her orthopedic surgeon. Said, "Don't thank me, it was my PA who did all the work."
Yeah.
And I feel like they don't get as much credit as they deserve, and I'm glad that you said that. And so our next question comes from Ricky Solis. He's a health science studies major from San Antonio, Texas, and he asked, why did you join the Waco Heart and Vascular Clinic after graduating from UT Galveston?
Easy answer. It's the only one who offered me a job. So the beauty of being a PA is that you don't have to go to a residency or a fellowship program, so you don't have to specialize. Our specialization occurs on site, whichever job we get. And some people go into it knowing that they want to do pediatrics, or they want to do family medicine, or they want to do ER, they want to do orthopedics. I went into it knowing that I wanted to do three things: cardio, family, or I think that was it. Actually, maybe only two things. So when my efforts to get a job with a primary care practice or a family medicine practice failed, shortly after, the opportunity to work with Waco Heart and Vascular with cardiology came up, and I jumped on it. So that's the simple story of how I got to the position that I'm in now. It was a very fortunate opportunity.
Wonderful. And I do apologize if I pronounce this wrong, but Ishwarya Loganathan, a psychology major from Fremont, California, asks, what is your motivation to keep strong when it gets difficult to balance everything?
Well, balancing requires there to be something on the other side. So if you don't have a job, you can't afford the other things. So there would be no balancing involved. That was a crappy answer, I'm sorry. So, no, I'm just joking. The motivation is that this is the path that I chose. This is the career that I chose. I made jokes about it in the beginning, but if you're not in medicine to help people, then you're in medicine for the wrong reason. So helping people and caring for your community and treating the people that you've been surrounded by, whether directly or indirectly, for your entire life, in my case, is the motivating factor that things are difficult, but I got into this business to make changes in people's lives. So everything else is secondary.
Beautiful. So our next question is from Neha Virani, a public health major from Houston, Texas, H-Town. And they ask, what would be the best piece of advice you would give to students pursuing a career as a PA, And is there anything in your undergrad career that you would have done differently?
Lots of things in my undergraduate career that I would have done differently. And I kind of hit on it to begin with. You know, I went to Corpus Christi A&M my first year, or freshman year, and I was a BIMS major then. I wanted to transfer to main site, so I dropped to biology because I, for some reason, twisted that in my mind that it would give me a better chance of getting accepted. All that to say, it doesn't matter what your major is as long as you do well in your major and get the prerequisites. But I wish that I would have maintained associations with the medical societies, with the PA societies. I wish I would have done better in OChem and physics, one. I did pretty well in physics too, but I knew the guy. But OChem was a train wreck because I didn't study. I didn't know how to study at that point. Mm-hmm. And then, you know, there's tutor programs, there's tutor companies that you can actually pay to go to a tutor lesson. I don't know if y'all have them here. At A&M, you sat in an auditorium and a guy taught you how to do the test. It was amazing. I didn't get that until like my junior year, you know. So, but that comes back to it. Make sure you're putting into the effort and you're dedicating time to your school, because that ultimately is going to decide what you do for the rest of your life. What was the question again?
It was just talking about, is there anything that in your undergrad career that you would have done differently, and any piece of advice that you would give to students who want to pursue a career as a PA?
Yeah, so for those that want to pursue PA, make sure you're doing it because you want to be a PA, not because you don't want to be a doctor, okay? And this is something that I've come to understand as far as my personal experience goes, that I didn't want to you know, to be, really I didn't want to take the MCAT, I'm sorry, that's the truth of it. But, you know, some people make the decision because they don't want to be a doctor. No, do it because you want to be a PA. Do it because you understand what a PA is, what their role is, what their limitations are. Know that you're not going to run the show 90% of the time. Know that you're not going to be operating alone 1,000,000% of the time. Okay, you're just not going to do that. But be a PA because you want to be a PA. Understand what that means, understand what you're going to be doing, so that you don't get in there and just realize, well, that was a mistake. It's not a mistake. PAs are great. I'm one, if you didn't know. And I enjoy it.
Yeah, and going off kind of what you touched on about the majors and stuff, Jessica Fan in biology and cello performance major.
Cool.
From Edmond, Oklahoma. She asked, do you think that biology major is seen as generic when applying to medical school?
No, absolutely not. No professional school cares one bit about your undergraduate major. As long as you do well, as long as your GPA is competitive, and as long as your prerequisites are completed. A guy I went to school with was a film major. We have a lot of business majors. We have a lot of finance majors. We have a lot of engineers. So it doesn't matter at all what your major is, as long as you do well in it and you get the prerequisites completed.
Good. How are we doing on time? Good, okay. So my next question comes from me, Cameron Campbell, biology major from Houston, Texas. Let me see how I want to put this. As we were talking about before, I'm a steel mechanic, so I fix small engines. And whenever customers bring in their machines, I always use it as like an analogy for medicine. There's an issue wrong with their machine, and I've worked on hundreds and thousands of them. I know either immediately what it is, or I'm going to have to take a look at it. And whenever you dive into it and you take it apart, and sometimes it's like, oh, it's a leaking oil seal or a cracked intake manifold, that moment is so satisfying. You're like, that's it right there. In the case study that you were showing us, you know, it's so difficult, like sometimes trying to find out what exactly is wrong. How would you say, how often is it where they just come in and you know immediately this is what it is? Or is it more so you really don't know and it's going to take a lot of work in order to find out? And is there some kind of satisfaction with that? Because it's not a matter of if I can fix a chainsaw. For you, it's sometimes life and death.
Yeah, so majority of the time, if they come into clinic, You don't know. You have a guess, you have an understanding that they might have something going on, but there's no way that, from the first jump you understand exactly what they're dealing with. So, collecting that information, looking at the patient as a whole, not going in with any preconceived ideas. I think that the majority of patients that I say, I know exactly what's wrong with you, it's reflux. And it's easy reflux. It's like I had chest pain after chicken wings. So in those situations, I can pretty well predict what we're going to do. But majority of cases, no, it's a step-by-step process of making sure that you're covering every single base. Yeah, kind of like I did on or hinted on the case study. It could be this, and this. So why is it this? Why is it not this? Why could it be this? Why is it absolutely not this? And why is it maybe this sometimes? And then you break each one of those things down and you do the respective testing, you do the respective investigation, and then you start checking it off and ruling off things, or ruling out things. Unfortunately, sometimes you check off one thing and then it amplifies the other one, but then that amplification looks back at this one and says, well, maybe it is this one. Maybe this is a heart attack with reflux complication versus, just bad chicken wings. So kind of coming back to your mechanical metaphor, I piddle with mechanics as well. I have a 2003 Dodge that I've kept running so far, and I'm pretty proud of that. So fixing something, whenever you think it's that problem, you replace the part, and then it craps the bed, that's pretty dissatisfying.
Oh yeah.
Fixing that part and then it runs very well, I can tell my wife that was an important part that I could have, that I paid for instead of buying a new truck, right? So, yeah, man, I think coming back to that initial statement of you typically don't know what's going on. You have an idea. You know it's a chainsaw, all right? You know it's supposed to cut wood. Sometimes you don't know why it's not cutting wood. You just got to take it apart.
Mm-hmm. Exactly. All right. Well, our next question comes from Timothy Blackstead. He's a biochem major from Broken Arrow, Oklahoma. And he wants to know, what is the difference in the educational training between a PA and an MD/DO? If you could go a little bit more detail into that.
Broken Arrow. I went to Broken Bow, Oklahoma. And that's like the Sasquatch capital of the world. Anyway. So let me start off by kind of explaining the PA training program. So it's typically 2.5 to 3.5 years. Okay, so in comparison, a medical school training is 4 years. PA is 1 year didactic, school book, testing, lectures, followed by the other year or year plus that's in the clinicals. Medical school is typically 2 years didactic plus 2 years of clinicals. So we're kind of cutting, half of the medical school curriculum in the PA. The benefit of being a PA is that you are trained with the medical school, not profile, but you are trained in the medical school. So you are getting, the teachings and the materials from a medical standpoint versus a nursing standpoint, which would be like a nurse practitioner. Nurse practitioners are great. But it's a different learning model. PAs it's a graduate school. We are in class 5 days a week, studying on the weekends and for that year, and then we are in clinicals for that next year and a half, 2 years, whatever it is. It's a full-time job. This is not a weekend, overnight online graduate degree. Okay, so this is every single day for the next 2 to 3 years of your life is graduate school versus medical school, which is also intensive. Like I said, 2 years didactic, 2 years rotations, clinical rotations. But then the main difference is that after you graduate your PA program, you are in the workforce. Whereas after you graduate the medical school program, you are applying to residency. And that's another reason that some people do find PA much more attractive than MD, DO, is because you graduate your graduate program, you are immediately a viable candidate to get a job, a well-paying job. And you don't have to pick what you want to do for the rest of your life at that time. I'm in cardiology right now. I have no anticipation of leaving cardiology, but if I wanted to, I could be a podiatry PA. But unfortunately, and fortunately, because you don't want someone who's flip-flopping as a doctor, but MD-DOs, they get a residency, they are a cardiologist, they are a orthopedic, there's no transition. So I think that in itself is one of the main attractive features to PA versus MD-DO.
Alrighty, well that concludes the Q&A portion of our meeting today. Thank you all for tuning in, and thank you for submitting your questions. Please look out on the weekly email, and we will see you here same time in 2 weeks. Thank you very much. Keep yourself and Waco safe, and thank you, Ethan Geiger.
Thanks for having me.
Thank you guys so much for watching. That's all we have for you guys tonight. Go ahead and click the like button down below, as well as leave a comment if you have any questions for the officers. Go ahead and click on that Google form link and fill it out so that you can get your points for attending this general meeting. Go ahead and subscribe so that you can get updates on all the general meetings as well as other events that we will be having recorded in the next few weeks. And follow us on all social media at BMSA_BU to keep up with all the fun. Thank you guys so much. Have a great night.
I can't wait for you to come my way. I've been far away.